All right, everybody, thank you very much. We're live on our broadcast. So, a warm welcome to those attending and also those our viewers watching live on the Council's YouTube channel, Hillingdon, London. This is the meeting of the External Services Select Committee. My name is Councillor John Riley and I'm the chairman of this meeting. A key role of this committee is to monitor the performance of local public services within its remit and to hold in-depth reviews on topics of resident interest. We engage in a range of external witnesses, in our activity, which can include community groups, residents, and subject matter experts. Where we identify areas for change or improvement, we make recommendations to the decision-making cabinet. Details of the business to be considered today is shown on the agenda, copies of which are available in the room and also accessible on YouTube underneath this broadcast. For those present in the room and intending to speak, please note that you will be filmed and any statements you make will be recorded and made public. For those in the public gallery, you won't be on camera. A reminder to councillors, officers and those speaking today that you should turn the microphone button on when speaking, and this will ensure that you can be heard in the room and by those watching online. What will happen is that as people speak, they can introduce themselves so that those watching will know who is speaking. So, on with the business. And welcome to this meeting. It seems quite a little while since we had one. And I have to make some further announcements, some housekeeping announcements. Before we get started with the main agenda, some quick housekeeping messages. Fire alarm. We're not expecting a fire drill, so if the fire alarm goes off, please follow our officers to the fire exits and out of the building to the designated meeting point, which is the Civic Centre forecourt. Mobile devices. For those of you in the room, please switch off any mobile devices before the meeting starts or put them on silent. Please note that some councillors may be using tablets or laptops to view the agenda. Residents' feedback forms. You're welcome to give feedback about this meeting. Resident feedback forms are available in the room and there's also a version online under the broadcast. And that's it. Excellent. Good. Right. So, as I said before, it seems a very long time since we had one of these meetings, and that's probably because it was. But for various reasons, we had to move earlier meetings, and so now here we are. So, apologies for absence, and to report any substitute members, please.
Chairman, we have Councillor Brightman here as a substitute for Councillor Dennis. Councillor Allen is a substitute for Councillor Lakmana, and we've had apologies from Councillor Radia.
Thank you. I understand that Councillor Lakmana has either been in or is about to be in hospital, so can you convey our good wishes to her and hope she makes a speedy recovery, please? Thank you very much. All right. Declarations of interest in matters coming before the meeting. Anybody? No. All right, thanks. There are usual ones, but we don't need to clear them. All matters will be in Part 1 will be in public, and any items in Part 2 will be in private, but we don't have any Part 2 issues at the moment. All right, meetings from the previous meeting, which was, the 9th of October of this year. And to a large extent, you'll remember that we looked at the dental health provision of services, which, and I'll paraphrase pretty much everything that's been said in the minutes, because the upshot of a lot of our questioning and our concern as a result of questions and answers and finding out where we were in terms of particularly dental health services for children and vulnerable adults was that we're going to have a select panel, which you will see later on under item 6, which will look into dental services, because we discovered in the relatively short time that we had last time that there were quite a number of areas that we wanted to look into and across the board in various ways. And as a consequence, as I say, we're setting up the select panel to drill down, and that's probably not the right expression, is it? But to look at the working of the various agencies and to see how things are going, because we were very concerned last time as to what we'd heard. So that takes care of that, unless anybody's got any specific questions about the dental side. We then had an update on the Mount Vernon Cancer Centre. You remember that there'd been a report previously about the centre. Caroline, anything further so far on that, or do you want to come back to it later on?
I can pick it up now. There's, at the moment, I think the main process in place is just the confirmation of, or a process underway to confirm who the likely sort of provider of those services will be going forwards. We've worked closely with East and North Herts Trust, so they've come to the CCG to give us some assurance around the sustainability and the some of the work that is going on to make sure that the quality and sustainability of those services in the interim is of a good standard, and I think we are sort of assured that we will be keeping in close contact through the next stage of that process to determine what the future is. So I think probably towards sort of March time next year we might have a bit more information, and East and North Herts Trust will be able to share that as well. So.
I think there might have been some confusion in a sense about what's there at present in terms of what patients can access, and because certainly the review talked about different support services and different aspects of cancer care that weren't there but needed to be linked in with what we've got at Mount Vernon. How far has that got in terms of there was talk about linking up with a major cancer hospital?
Yeah, and I think that's the next stage in the process, is to work out what those connections are, and then further conversations and decisions could be made really on what that model of care then looks like, and therefore what you would have locally delivered in a either Mount Vernon or a local centre versus what you might want in a more specialist centre. So I think until the next part of the process has played out, that's the point then at which we can start having those more detailed look at what those models of care might be.
And I seem to remember, it's quite a little while ago, that the compilers and authors of the report said they'd come and talk to us about where they were with the process and what the report, and cover some of the aspects of the report. So do you think that'd be a useful thing for us to get from them?
Definitely, and I think they're very, certainly from the conversation we had with them at the CCG, they are really keen to continue having those conversations. So I think they'd be very keen to come back, probably, like I say, towards sort of February, March time, when they've got something a bit more confirmed that they can talk through. So, yeah.
Nikki?
I have actually been in conversation with NHS England and been advised that they are looking to come back to us in our February or March meeting. I've also been talking to the scrutiny manager at Hertfordshire County Council, who is looking to arrange a site visit, and wondered whether our members would be interested in being involved in that.
Well, I'm sure we certainly would, and the more interaction we can have with other agencies, the better. Councillor Nelson.
My apologies. I understand from some of the staff that the wards will be reopening in January, that there's some work going on, and by January the wards will be reopened. Can you update on that or confirm whether that is true or not?
So I'm not sure about the cancer centre. There's the Michael Sober House ward, inpatient ward, that will be reopened, which is being refurbished at the moment, and I think the 5th of January currently is the proposal to reopen that. But I'm not so sure about the I didn't think there'd been any closures to the cancer wards over there. So I think that one of the complicating factors is there's many different services on the Mount Vernon site, and I think there are which East and North Herts as well used to be involved in the delivery of the Michael Sober House. So I think there's maybe two separate services that we're talking about. I can check whether there's been any changes to the cancer wards, but I'm not aware that there have been.
That would help if we can have that information, because it's conflicting information, and I just said I will clarify that, because what you're reporting is what I heard, but this is what came back to us. Thank you.
There may be some configuration of things being said about cancer services, because certainly the Michael Sober House situation was that patients from Michael Sober House had been moved into wards in Mount Vernon and to the cancer wards, and with the sort of inquiry that the committee had and the resulting coming together of all the parties, Michael Sober House is reopening as an inpatient centre, And I think there was an opening on Monday, an event on Monday, and similarly another event at the weekend for friends and supporters and people like that. So it may be that that's what's happened, that people have said, well, people are moving out. The Michael Supple House patients are going to be moved back into Michael Supple House Centre, the hospice, and that's now going to be up and running as it should have been 12 months ago or more, when we had all that business about it closing. But as far as the cancer wards are concerned, where treatment is given, the review, I don't remember the review talking about any movement of staff or anything like that, and that'd be far too early anyway, because what the review is talking about is a long-term cancer provision in a much wider sense. So I'd be surprised if that was something that was happening, but as Caroline says, she'll follow that up. All right, thank you. Any other questions on that one? All right, thank you. So we did the GP pressures report came along, and it was sort of agreed and passed by this committee, and that'll go to Cabinet, I think, in January. Yeah, all right. So apart from that, has anybody got anything else on the minutes? All right, agreed? Thank you. All right. So item 5, health updates. So I think. Oh, right, okay. So we're going to deal with the CNWL first, please. Right. Hi. Hello.
Okay. Hello. I'm Kim Cox. I'm the Borough Director for Mental Health, and I'm here to talk about all of the services that CNWL offer in the borough currently. With me is our Chief Operating Officer, who is Robin Doran. I've done this in the usual model that I do. I will just say that the SIM officer isn't able to join us tonight, so she will be coming to the next meeting, Nikki, please, if that's okay. Thank you. So just to state, I've started the presentation here with a very brief overview, as I was asked to do a couple of meetings ago, actually, about our integrated care connection expansion model, which is very much about integrating the community physical health care services that we offer in the borough alongside some of our mental health services, and of course in conjunction with our colleagues in Hillingdon Hospital. And I've brought the pictorial for you because I've tried to explain it 2 or 3 times, I think, and I haven't been able to explain it very clearly. So I've brought the pictorial, and then over the page there you will see the way that the new models of care and the primary care networks are set out, and each of the neighbourhoods will serve a population of... I thought you said the buttons weren't working. Sorry. No, not that one. Yeah, okay. There we go. Thank you. So the neighbourhoods will serve a population of between 30 to 50,000, and I've mapped those out there in the borough for you, and they will involve partners from across the systems, our acute colleagues, our community colleagues, our mental health colleagues, our primary care colleagues, some social care, and the third sector. Clear focus on prevention. There's data and information sharing across all parts of the local system, although that isn't quite as seamless as you would like to think. It is there and it is available. There are multidisciplinary teams working across all the organisational boundaries, and there's robust data driving developments, including the use of the whole population risk stratification. You'll be pleased to hear the public health, Dr. Hadjioff there. And it's a community asset-based approach to managing the health and well-being of the local population. So that really means that we'll be able to identify where there are pockets of certain types of long-term conditions and common problems, and be able to target those areas with the relevant number and professions of the staff that are required. And as I said, the resources are totally flexed to, and the workforce are flexed and deployed to meet the needs of the population. And that was something that I'd had lots of questions about previously when I've attended these meetings, and just thought it would be better to show a clearer pictorial version there. In terms of our children's services within the borough, in terms of positive updates, there's a new children's integrated therapy service which is being mobilised, and this is combining our speech and language therapy, our physio and our occupational therapy pathways into a more seamless service with a single referral route. And you'll see there, I've just written down on the side there some of the points that they are able to offer, and this is seen as integrating this service for us has been a real bonus, and I think it will certainly be better for the children and the parents as they're moving forward. And then onto the mental health services. So the referrals continue to increase within the service to mental health services, and that is why we have really mobilised quite a lot of our resources into primary care to see if we can signpost secondary care referrals and stop people deteriorating. There's a major transformation plan in place to improve our urgent, acute and community care offer. Although this has been impeded, we have had to halt some of this transitional work due to the Council withdrawing from the Section 75 Integrated Services Agreement, which I'm assuming that you were aware of. And the additional we have received additional funding through the additional funding that is coming into mental health services to instigate a bespoke community service for people with a personality disorder. This was something that we didn't have in the borough, and we're delighted to this. This is going to be in the form of a virtual, what we call a virtual therapeutic community, which means it will be in part be run by the service users, but will be supported by highly trained psychologists, psychotherapists, and nurses, and other healthcare professionals. And we also have received some additional funding to enhance the mental health primary care offer in conjunction with the neighbourhood teams. So at the moment there are only 4 primary care nurses in the borough, and the additional funding will enable us to have 10 to 12 primary care nurses across the borough, which will be a huge bonus, as well as being able to have potentially a local point of referral for our GP services and triage for the non-urgent cases that are coming through. Over the page, I've got some good news about the CAMS services. I know that's always been quite a focus of the committee. So we have the new 5-borough team in place with the aim to avoid admission, and this is about having home treatment offer for the CAMS children in the borough, which we didn't have. And the Lavender Walk, which is our inpatient CAMS service locally that we commissioned, has had its 1-year anniversary, and we've had really positive feedback, excellent outcomes, and 12 children from Hillingdon were actually patients on that ward over the course of the year. These are 12 children that would have had to have been sent way outside of London in the past, so that's a real positive benefit. In terms of the challenges, the 18-week target, so this is the 18-week referral to treatment plan, was missed for the quarter. There is a recovery plan that was put into place for that quarter, and we are now back on track in December. And because of the additional investment into children's and adolescent mental health services countrywide, the workforce recruitment and retention remains a bit of a challenge, because there are so many more jobs available for people, and we're not quite training enough. Over the page, we were asked to look at the numbers of compliments and complaints, and this is taken directly from our quality account, which I believe you'll be getting a full copy of fairly shortly. And this is for our mental health service. Our complaints average 4 complaints per 1,000 patients. That actually accounts to, in real terms, probably maybe 1 or 2 complaints a month. Some actually have had no complaints for the last 2 months, but previously you might get 4 or 5. That's how it works out. The key learning and the themes that we learnt from the mental health was about increasing the communication between the staff, clearly conveying our complaints procedure. So some people complain that they didn't know how to complain, and then we didn't explain it very well back, which was fair enough. And one of the things that we've learnt really is about creating opportunities for staff reflection on their behaviour. Some of the complaints we get are very much about attitude towards people, and we have now set up a process of not just saying to the staff, well, that wasn't on, but we've actually asked the staff to meet with the patients again and examine that whole interaction between themselves. Complaints for our community health services are really low, 0.3 per 1,000 patients, which is very good. They do have compliments, average 2.2 per 1,000 patients. Actually, you can see from the mental health side, we do receive more compliments than we do complaints for the services. And this is an aside to our friends and family testing and our other methods of testing. And the key learning there, again, it's all about communication. It's not necessarily about treatment. It's all about communication and attitudes moving forward there. And over the page, I've just done a little summary of the amounts of activity. That was a question, again, that I received a few meetings about how many people do you actually see. You will see that our Hillingdon Adults Community Services activity is huge and increasing, and at about 32,000 appointments a month. And Hillingdon Mental Health, last year we did 72,000 face-to-face contracts and over 20,000 new appointments. And I've just done a little summary there as to the end of that. I was going to hand over to Robin. Robin would like to say a few words.
So I guess I'm going to end on a less positive note because I think on behalf of the Trust Board I just want to express our disappointment at the Section 75 notice that we were given. Not only at the fact the notice was given, but the way it was given. This is a borough that we have worked in for over a decade. I've personally sat in this room for at least the last 12 years. We've talked about partnership and working together, and we believe together, and we're a good partner, that we've developed some really good services in this borough, and particularly in mental health. So to receive out of the blue without any warning notice of the Section 75 with 6 months notice only, including to our accommodation, was incredibly disappointing to say the least. More importantly, we think there are two key points that the Scrutiny Committee needs to be aware of. Our experience of this around the country is that this does not improve services to patients. In fact, it's a retrograde step and frequently has a huge impact on the recruitment and retention of social work staff. And secondly, it will have an impact in terms of cost shunting of finances particularly in relation to our rent, which will have an impact on our CCG and our health colleagues.
Well, I think what could be said about that is that I know that the Council's view is different to CNWL's, and that there have been high-level discussions about this, and that the decision taken was based on past experience and concerns surrounding that. But essentially, there is a division of opinion about how that all fits together and works, and that's the result has been that the Council have acted in the way they have. Dr. Hatchell.
Thank you, Chairman. I wanted to talk about something else, but I'll just touch on the Section 75 issue. I don't have a direct involvement with it, but I'm hopeful that even with different organisational arrangements, we can still have the same level of integration in service delivery for the benefit of all of our residents, even if it's integration across organisations, rather than a sort of virtual organisation that brings people together. No, what I wanted to touch on was the personality disorder service, because I think that's extremely positive, and I think is extremely important for our residents. And I just wanted to triangulate, if I may, why that is. Because people hear personality disorder and they think of antisocial personality disorder and crime and disorder and all that sort of thing. Now, that's important. But actually, there are very large numbers of people with personality disorders who are extremely vulnerable. And so having a service that supports them can greatly enhance their lived experience. But it can also help us in other ways. There's a particular personality disorder called emotionally unstable personality disorder. And certainly the conversations I've had with Arch, our substance misuse service provider, say that a lot of the people that they're dealing with, that they're struggling to deal with, and this is also CNWL, of course, that they're struggling to deal with from their addiction point of view, they're struggling because they've got emotionally unstable personality disorder that we haven't really had an ideal means to manage up to this point. The same is true with people who attend A&E very frequently. The same will be true, I'm sure, for mental health services, for our social care services, for our housing services as well. So I think that there's potentially a real benefit not only to residents through this service, but also to our health partners and to this council. And if I may, through you, Chairman, I'd like to applaud CNWL for taking the initiative in this way. I think it's really, really important and helpful.
All right, thank you.
Sorry, there was just a few of us that wanted a bit more explanation on what this Section 75 actually was.
So I'm not the expert and I'm not directly involved. My understanding, and I think colleagues from CNWL can probably answer it better than me, is it's an arrangement whereby there is a sort of ongoing contract between two organisations where they will in effect share staff and have an integrated sort of management arrangement. And therefore social care staff were fully embedded into CNWL mental health services, Mental Health Act related mental health services under this agreement. Now with the end of that agreement they're no longer embedded, but what I was trying to say earlier is that doesn't mean that that they have to not work well together and not work seamlessly. But as I said, I have a peripheral understanding, and I'm sure Kim knows much better than me.
So what this meant is that we had the social workers, the nurses, the OTs, the doctors and other therapists working in an integrated team in the same base. The disaggregation of the Section 75 means that we're having to split the caseload to service users who have either a predominant health need or a predominant social care need, which is quite a challenge because the reason that we had the integrated service was because most of our service users have both. The social workers are coming back into the civic centre. We actually were located in two of the council's buildings, one at Pembroke and one at Mead House, and we're now looking for alternative premises, which means that we're having to design a model of care really for community mental health services, which is predominantly just health-based, and the health offer and social work service will be operating here from the civic. I don't know, that's what it was in a nutshell.
And I guess the evidence base, whilst our intention would be to do whatever we can to work closely together,
Absolutely.
Our experience of this is, and we have this model in Milton Keynes, and actually they're co-located, as it doesn't work as well as the previous model does. And the fact that in this case we'll be in very different locations makes it quite difficult.
There were concerns within the council about the way in which the social workers were working and the sort of work that they were undertaking. And I know this was a very complicated and gone into in some considerable detail as far as the council and their staff, essentially, because the social workers, as you say, were almost on loan, as it were, or at least, working with, working with CNWL in these units. And there were some, and this is where the division of view and opinion comes. There was some significant concerns on the council's part as to what the social workers were doing and where they should do it. As far as the accommodation was concerned, I'd understood that there's a lead-in time in which the remaining services can look for other places, but it wasn't a question of anyone being kicked out or anything immediately. But nevertheless, I understand that there's been time made available.
So yes, we were given a further 6 months at a very reasonable rate, but it was only a 6-month lease, and then we would be looking back up to market value premises for 2 large sites. So we have started looking to move our community base possibly into a central base within the borough, because that's about as far as our resources will manage, really. But
again, the idea of just because there's been a rearrangement of personnel, as Dr. Hadjov said, doesn't mean that they can't work well together. And I know you said that the aim would be that they should, it'll be kept under review, no doubt. But there was a significant divergence of view as to how that whole system was working. All right. Can I ask about? We touched on this before about the Zero Suicide Alliance.
So the zero,
can you help us with that?
yeah, so the Zero Suicide Alliance, so the discussions that we've had before, we've just managed to upload the Zero Suicide Alliance training onto our electronic education system, and all staff will have completed that training and be able to complete that. As part of the additional services actually that we have, that we put the bids in for against the transformation funding, we also were successful in getting some training money to offer our community health, and not our mental health, but our community health staff some enhanced mental health training as well, and vice versa, as well as some funding to give all of our staff some training in a therapy called dialectical behavioural therapy, which will be able to help them to move forward, especially with the client group that we seem to have increasing within the borough at the moment. So we did get that bids for that additional funding as well. So, yeah.
All right, thank you. And you touched on it before. You touched on it before in terms of complaints when you went through the your report.
Mm-hmm.
Previously, I think we'd asked about a breakdown of complaints received in 1819.
Yes.
And before you said that quite a lot of these complaints were not about service, but more about communication and things surrounding service.
Yeah. Yes.
And is that what you found in the
yes,
1819?
absolutely, and that's absolutely what we found across both the Hillingdon Mental Health, Hillingdon Community Health, and indeed within some of our other services. They're not necessarily about the services which are provided, but more about, letters being sent out late, not informing people if clinics were running a little bit late. And sometimes the message that service users will receive, and in some cases that might be actually you don't necessarily need our service, they are not particularly happy about. So that is the common themes that we're seeing coming through at the moment.
So what sort of percentage were, if not all of them were just about service?
No.
But what sort of percentage were about delivery and service itself rather than communication and sort of peripheral matters?
Probably very small, probably about 15-20%, if that. And you can see the numbers of complaints that we get are quite low as well, considering the amount of people that we see, which is why I included, 33,000 people a month within our adult services, and probably about 10,000 face-to-face contacts roughly across the board, 3 inpatient wards and all the other services. So they're relatively low level of complaints.
And the other thing that we touched on previously was advanced care planning in care homes.
Yes. Yeah, I'll let Caroline explain that one to you.
Right.
Yes, yeah.
So the CCG have been working with Hillingdon Health and Care Partners, which is both the General Practice Confederation and also CNWL, in particular on this model, around some sort of additional clinical support into our care homes in the borough, which is really to try and reduce the demand or unnecessary demand on A&E and the front door of the hospital, and also to improve the patient experience, so as much as possible to keep people in their usual place of residence. So that's got a number of strands to it. One is very much around the advanced care planning, so making sure that people have got care plans available. We tend to use something called Coordinate My Care, because that is an interface that LAS, the London Ambulance Service, can also access, so they'll have access to those care plans as well. But also there's a level of urgent response as well going into some of those care homes now. So I think we've got a good multidisciplinary team with some good senior nurses supporting the care homes, in addition to the GPs, obviously. I think we've got dietitians supporting as well. So it's a strong
mental health,
supporting all of those sort of wraparound services to try and support the care homes in the borough, of which we've got sort of quite a few of varying levels. So
what's the sort of coverage per care home in terms of, is it one team or is it a number of different teams?
So it's not as precise as that. At the moment it's been rolled out, so it's just being rolled out at that enhanced level at the moment, and it's based on sort of prioritisation of the need of the care homes. So I think we prioritised 5 or 6 in the first instance, where we knew that sort of they were large care homes, where we knew there was a high sort of level of conveyance rate into Hillingdon Hospital. So it's a phased rollout at the moment. So it'll be borough-wide sort of by the end of the financial year, but at the moment we've just focused on some of those high levels, particularly during the winter, because we think that's where we're going to have the biggest impact on the system.
All right, Councillor Arlen.
Thank you. It's just a question on the figures here on the mental health. So last year we did 72,000 face-to-face contacts.
Yes.
Presumably that's the same person more than once.
Could be, yes. We
Because
didn't see
otherwise
72,000
No,
new
because otherwise
people,
it'd
no.
be 1 in 3 in
Yeah.
Hillingdon. So.
Yeah. So we did see 20,584 new appointments though as well. So that could be, some of that might be in our talking therapy services as well. So.
All right, thank you. Any other questions? No? All right. Caroline.
So, unfortunately, just revisiting the point around Section 75, and it's more of a process point, I suppose, from a CCG perspective and from a health perspective, is that we are probably going to have to go out to consultation on some of these changes. And I suppose it's just, generally in the course of things, if there are things being out to consultation, then the scrutiny committee would be somewhere that we take it. So I just wonder whether we can put it on for the next round when we have a little bit more information around what we think the impact is going to be. We're doing a lot of work at the moment around that, and then we can sort of share it here as well, because it would be consulted. So if you're happy with that, I think it's...
All right, thank you very much. Thank you. All right, so we move on, and we shall go to Hillingdon Hospital. And very warm welcome to Sarah. Thank you very much.
Thank you very much. So it's good to be here. So apologies that you don't have a presentation tonight. We will make sure going forward that you do. But I've hopefully picked up the areas that you'd like us to talk about. So the first area to cover off was around the Hillingdon Improvement Plan, which is our response to the CQC report that we had last summer. So we have reviewed the improvement plan, and obviously we wanted to address the should-dos and must-dos that came out as part of the report. But it was also very much about making sure that as we move forward, our systems and processes are such that we don't find ourselves back in that position. So we have revised the plan. We currently have 13 work streams, each one being led by an exec director at the hospital. And as I say, picks up the key areas that were identified. The focus at the moment as we move forward, a lot of the areas we have tackled. We are looking very much at our ward accreditation process. So this is a process to make sure that all of our wards are achieving the correct standards. That's well underway. Now we've done a baseline assessment, and we're now going back for a second round, and we're seeing some significant improvement, so we're very pleased with that. We've also done quite a lot of work around management of patients with sepsis and the deteriorating patient. Had a number of deep dives around that. And again, that work continues, and that's about making sure we've got those systems embedded across the organisation. We're also reviewing currently our infection prevention and control processes at the moment, and making sure that they are as they should be. A very significant piece of work is around our estate, and I'll come back to that, but making sure that we are optimising the estate the best that we can, recognising that we very much need new builds. And then underpinning all of that is work that we're doing around our policies and making sure that they are up to date and mean that we can move forward in the right way. So a significant plan of work, lots has been done, there's still lots to do. We meet fortnightly to review the plan. Once a month at those meetings we are supported by external partners, so Caroline's there from the CCG. We have representation from NHSE and I as well as the CQC themselves usually dial in. So it's important that we're getting that overview to make sure that the work that we're doing is getting the desired results. We also have set up an evidence committee, which again is supported by external partners, so that as we feel that we have addressed the issues that have been raised, we then provide the evidence, and again it's making sure that it's just not just our internal view of the world, that we've actually got external scrutiny to make sure that we are all confident that we are moving forward in the right direction. On the 4th of December we had a peer review, which again was made up of internal staff as well as external staff, and we reviewed the non-clinical areas. So we didn't go to the wards, but we looked at all the other departments across the hospital in relation to what we would expect to see as part of the CQC inspection. We're just pulling those results together, and obviously very happy to share that as we move forward, what that looks like. There were some areas of good practice, there's some areas where we still need to do some work, so we're very excited on that. So we do feel that the work we're doing is moving forward, is moving in the right direction, and obviously we are keen to get a revisit and make sure that we get the desired results when that happens. But a lot of work going on at the moment. The next area I wanted to cover off was the winter plan, so that you will see I've put a handout on your tables. This is a response across Hillingdon Health Care Partners as to how we are going to tackle the pressures as they unfold across winter. We are already in winter, in case anybody's missed that. There's lots of pressure in the system already. Just on the first page there, just the top line, don't want to spend a lot of time on the numbers, but the top line there identifies what we think will be the increased demand that we can expect on beds across the hospital as we move forward. And then the next line talks about the additional capacity that we have planned to tackle that. And you'll see that actually what we've very much tried to do is plan in excess of what we think the demand will be. If we move over to the second page, you'll see the areas that the system has been working on to tackle this. So the green column that you can see there is around admission avoidance schemes. And that's looking at how do we manage patients, and it goes back to Caroline's point really, closer to home, so they don't need to come into hospital, but more appropriate settings if possible. And there's a range there of schemes that we are looking at and how we will manage that. Happy to talk about any of them if that's helpful. The next area is around the ambulatory schemes that we've got. So patients previously with conditions may have been admitted to hospital, and with the advances in medicine and technology, we don't need to admit all those patients. So we have expanded our ambulatory pathways. We're doing more and more of those, and we're seeing more patients go through that, and that's obviously better for patients. They come in, have the treatment that's required, and then go home or to a more appropriate setting. We're seeing some significant changes there, and you can see that gives us the equivalent capacity to 13 beds just by doing that. And then the last section there in the blue is looking at effective discharge processes. Now, and various schemes. This is a key work stream for us. This is about making sure, again, patients get home, preferably to their own home or to a place of safety, but it's making sure that they've got the right support where that should be. We anticipate that this will give us around the equivalent to 40 beds. So this isn't about moving patients out of hospital early. It's about when their treatment is finished, getting them to the right place of safety, but if they need a bit of extra support while they settle in back at home, for example, that support then goes in. So we are working very closely on this with healthcare partners. We have daily phone calls, we have system-wide meetings. We are constantly reviewing this because we need to. At the moment, the hospital is under tremendous pressure, and that's a picture, you'll have seen the news, that's a picture across the country. We have seen increases of up to 20% on attendances in ED just over the last sort of 10 days. That's significant. So that takes us from seeing potentially 220 patients a day up to 340. There's a big shift. Now, it may be a blip, but obviously it's so important that we continue talking to the system and working together to make sure that we can manage these patients safely. What we do have internally is very close monitoring of what's happening in the emergency department on a daily basis. So there are 3 times a day bed meetings and sometimes 4 times a day bed meetings. And by that we mean we're looking to how are we optimising the use of our beds and making sure that patients across the system are being kept safe. We have walkthroughs with the executive team through the emergency department throughout the day. We go down, we join the board meetings where the patients are being reviewed, and there are staff within the department who are constantly monitoring the safety of patients. So we have a nurse that's now in the waiting area to make sure that as patients are waiting, we're keeping them safe, but also through the other departments. So it's not just a safety thing, it's making sure patients are comfortable as well. So making sure they're having something to eat and drink, and we're keeping them comfortable. It is incredibly busy, but there's a lot of energy going into making sure that happens. There were some questions in the previous report that I thought I would just answer. I wasn't sure whether you'd had those answered, so I'll just very quickly whip through those. There was a question around how to contact the complaints team. I've put some brochures on the desk So there is one there about the patient advice and liaison service, and that's if patients want advice or their visitors do, and that's how to contact them. There's also some at the back there, and there's also the leaflet on the process of making complaints and how to do that. So I assume there was a discussion previously about that. There was a question about staffing levels in ED. As I say, through the meetings that we have 3 or 4 times a day, we constantly review the staffing, not just in ED but across the hospital, and decisions are made then if we have to move staff around. We try to keep that to a minimum, but we absolutely need to make sure that each area is safe, so we optimise the staffing levels in all areas, and as I say, constantly under review because that's where we need to be. As far as our A&E performance at the moment, we were, up until mid-November, we were running between early to late 80%. So up to 87-88% of our patients were being seen and treated within 4 hours through the A&E department. With the increase in numbers that we've seen, whilst we're not admitting more patients, which is good news, we have seen a deterioration in that performance, and it's running at the mid-70s at the moment. Again, that's a picture that is reflected certainly across London and in many areas across the country. So every hospital is feeling extra pressure at the moment. We are working with colleagues to understand that pressure. It's not particularly coming from the Borough of Hillingdon, it's coming from outside Hillingdon, so we need to do work on that. So I think that was the main questions that were asked.
What about TB vaccination?
Yes, yep, you're right. So we have looked at this. We are not currently contracted to do TB vaccination, so we don't. We've had a conversation about that, and we think that will change going forward, but at the moment we don't do the TB vaccinations from the hospital.
All right, thank you. We're very grateful that you've come along. For some time now, the committee's been very concerned about performance at Hillingdon Hospital. And you talk about pressures, and of course that's right, but we've been told about pressures almost every time we've had your colleagues before you come and speak to us. A lot of it is put down to the estate. Well, because there is a cyclical thing about the estate and the capacity to perform and decision making. We were talking earlier about the. Do you want to just turn that one off for a minute?
Oh, sorry.
We were talking earlier about the Mount Vernon Cancer Unit, but of course, in a sense, some of that depends on decisions made across the estate anyway, as we've been told in the past. And in particular, we were very concerned about the last major CQC report and what we heard as the response to it from your colleagues in terms of meeting the criticisms that were being made. I mean, we could spend a very long time on all of these heads that you've referred to, but one area, and it's just literally one area plucked out of the air, the discharge schemes. Frequently, and we've done, and other formulations of this committee in the past have done reviews about discharge method schemes and ways of dealing with things. We're still hearing from residents about awkward discharge circumstances, timing, waiting for medication, perhaps being there all day and then being told, well, but you have to stay overnight because we need to sort out your medication for the next day. All sorts of different problems in terms of discharge. And I just wonder whether or not, because of what we've heard being the great volume of problems, whether there's any sense of really tackling one area in a very significant way rather than trying to do everything. Because it's our experience, I think, over the number of years that we've been on this committee, that Hillingdon has consistently tried to tackle all the problems all at the same time. And then they talk about pressures, and then we get told that things can't be done because there are problems with the whole estate. And then there was a whole sequence of time when a new hospital was being talked about, not the most recent one, but before that. So I just wonder whether or not it's better to sort of take small slices of problems and try and dig down to those rather than trying to hit everything.
So I think that's a very good point. So the problems at Hillingdon, the estate is appalling. It cannot be blamed for all the issues that we have, and we need to be clear about that. So we are not trying to solve all of the problems immediately. We have a new executive team in, and over the last year, in fact, we have a new board. We have pulled together a very clear plan of what are our objectives for the next 3 years. So we have broken that down into bite-sized chunks. So what are we trying to achieve this year? What are we trying to achieve next year and the year after? So we're very clear about that. We've then underpinned that with clear objectives for all the staff this year. So what does this mean if I work on a ward? What does it mean if I work in X-ray? So everybody's very clear about what they need to do. So because you're absolutely right, we can't solve everything. What we do need to do is get the systems and processes working in the hospital. I have to say, when I got there, that was not working well. So when you talk about things like patient administration, we had nobody that was overseeing how those systems and processes worked. So depending which department you went to, you would have one experience, and if you went somewhere else, you would have a different one. Hospitals can't function like that. We have to have a business as usual, we have to have a business rhythm, and we need to have standard operating procedures to work to. So we are very much putting those things in place, and that's very much what we're doing this year. We can't switch things off, so our elective patients will continue to come in and should expect a good service, as will our emergency patients. So we do have to balance things, and we do have to tackle more than one thing. But you're absolutely right. What we're trying to do very much is do that in a systematic way. I'm very happy to bring that detail back to the next meeting and talk that through, so you can see clearly what that programme of work looks like. But it is a clear programme. It's not going to be a quick fix. There's quite a lot that needs sorting out. But I would be the last one to sit here and blame all of this on the estate. It's about how we've been working.
And I'm sure you're right, but you need to understand that we've heard this a lot before. And people have come to us and told us that this needs fixing, that needs fixing, but nevertheless we need to. And it's again, as I say, we're very grateful for you being here. But when you hear those sorts of things, first of all, it sounds like it's no more than might otherwise be obvious in terms of direction and what should be happening. To hear that you've come along and discovered, for example, as you just said, in patient discharge, that there wasn't somebody overseeing it, which tends to sort of back up what we're being told by residents who've been patients, that things have gone wrong. And inevitably that must have a problematical knock-on effect to other things. So when you talk about, I mean, I may be wrong about this, but when you talk about bed availability and all that sort of stuff, if the discharge system isn't working across the board, there's almost certain to be, I mean, 1 day's delay is a problem, isn't it? Yeah. All right. Councillor Brightman.
Thank you, Chairman. Thank you, Sarah. Regarding your discharging 10 before 10 a.m., could you tell me a little bit more about that? Because one of the sort of problems that I've witnessed is the prescription thing, because you can only fulfil a hospital prescription at the hospital pharmacy. Is there not a mechanism whereby perhaps a GP could be on site to hand out, pharmacy-orientated prescriptions?
So this is my day 3 in the trust. So I'm enjoying it enormously, I have to say. So I've been really involved with the before in the morning discharges, because clearly, as Sarah described, with the pressures there. So in terms of these particular patients, they're all planned the day before. Their prescriptions are in the day before. Their medications are ready to go the day before. What they usually need is a very quick medical review in the morning to say, yes, you're definitely fit to go, and then they leave straight away with their medications. So what we're trying to get into the habit of doing is planning those through the day, because absolutely you're right, we do have patients who are waiting for their medications. So we're just trying to get into a more systematic, as Sarah said, in terms of the processes, that patients are getting those prescriptions written earlier, so that by the time they're actually ready to go and their final tick in the box is you're fit to leave, is their medications is not hold up. So I think we are starting to solve that for those particular patients. because we're getting those well identified in advance. We need to just get that systematic process running through the whole day.
All right. I think it would be helpful if you were able to come back. We may even, and Nikki won't thank me for this, we may even look for, as we have done previously, just a special session with you and your team, because we've always been willing to help and to look into things concerning our hospital. And it worries us greatly that things have gone along in the way that they have. So we can't do everything tonight, obviously, and it would be useful. But if you were to provide us with more detail in terms of how things are going and what you're aiming at, that would be very, very helpful. And perhaps we can talk about having you back with your team to have a more in-depth look at things. But certainly, I mean, the number of different issues, problems, experiences that residents who have been patients have come to us with about discharge, really has been, and this is, as I say, a very tiny area of it, relatively. Things like being told that, well, you're going to go back tomorrow, home tomorrow, but you will need your medication first, and then anything between 1 and 4 pharmacists coming to see them, frequently asking the same question about, asking the patient the same question about what's in a medication and all the rest of it, and explaining, going through it, and then patients been slightly, maybe not confused, but sort of concerned that, well, why am I being told this 3 times, or why doesn't the other person know, or why isn't it being passed on? And it seems like there's no connect, even on that level.
So we would welcome the opportunity, because there is quite a lot to talk through, and we'd be very happy to do that. The reason that we're very focused on the ward accreditation process at the moment is to make sure that the wards are functioning as they should be and to the right standard. And part of that is incorporating discharge planning. So what happens with the multidisciplinary team on the ward to make sure that that patient is ready, and that includes the pharmacist and the doctors and the physios and the OTs and social service, so all of that. So I think it would be really helpful to come and have a more detailed conversation and share that.
Dr. Hedger.
Thank you, Chairman. I just wanted to come in on Councillor Brightman's question. And actually, there are mechanisms whereby hospitals can write community prescriptions. The problem is twofold. Firstly, they don't necessarily know whether the patient's going to fill the prescription and therefore actually have the drugs and take the drugs, and so there's a risk that they may not, or they may get further confused and they may end up coming back into hospital. The second problem is that if it's a community prescription, then the patients who are eligible for prescription charges will have to pay prescription charges, and those are I don't think they're ever levied for hospital prescriptions. Certainly. Very, very rarely, and that could be a further disincentive for people to actually get their medicines. So that's why it's important that the hospital pharmacy way of delivering the medicines to people as they leave hospital is got right, because actually the safety net has got bigger holes in it than it should, if that makes sense.
All right, Councillor Hall and then Councillor Mullally.
Thank you, Chairman. Just 2 really quick questions. You talked about the team and you've built a whole new team. Is that fully in place now?
Sorry, with the arrival of Tina on Monday, the team is now completely full. We do, however, have our Director of People and OD will be leaving us in February. He's going to Oxford University Hospitals, so we will need to recruit to that post. But at this moment in time, yes, we have a full team.
Excellent. And the second thing, and I've asked this to all of your predecessors as well, and that is the A&E targets. When do you expect to be able to hit that?
So the trajectory that we agreed this year was below that national standard, and in light of the fact that everywhere is currently well under that standard, I am not going to sit here and say we will be achieving it by X date. What we have to do is we have to continue the work that we're doing. We're certainly seeing an improvement in our systems and processes, but it is much wider than just what happens in ED, it's what happens across the system. And when we have sorts of increases in numbers that we've had, and particularly the size of the department we have, it does make it difficult to get patients seen as quickly as that. So I'm not avoiding the answer. We're very focused on the need to get there. We just need to have a rethink about what that looks like.
Thank you. That was a very honest answer. Thank you, Chairman.
Councillor Maloney. Councillor Maloney.
You've just said that one of your directors is leaving. Have you already started looking for a replacement, or have you got to wait till he's left before you replace him?
No, we've already begun the search.
All right, thank you. Well, unless anybody else has got any other questions, but we'll take you up on the coming back in more detail, and we'll take that up later on. I'm very grateful to you. Thank you very much. All right. So who's next? CCG, I think. I expect there's going to be some sort of slideshow or.
So just while Nikki gets those up on the screen, I was going to focus on two main areas. And for those of you who've got the paper copies in front of you, you'll see. So the first one is around development of primary care networks, and it really builds on some of the conversation that Kim was having around the neighbourhoods. And the second one is around the development of a single operating model for CCGs across northwest London. So, moving swiftly on. So primary care networks, these sort of really came out of some guidance following the long-term plan for the NHS. So from the 1st of July, all of the general practices in Hillingdon have been working towards establishing themselves as primary care networks. I suppose just for a bit of context as to how these link in with the neighbourhoods, we in Hillingdon, I suppose, were slightly ahead of the game in terms of thinking about what configuration do we want of our community services that are really based in the borough, and what might that look like going forward. And we'd already started to develop these neighbourhood models of care, which brought the primary care and general practice into much closer working relationships with our community health services and our mental health services. So we'd already started to have a look at what we called neighbourhoods might look like. And then that was sort of slightly overtaken then by some national guidance that came out around primary care networks, and some guidance within that around scale, so that they must be between 30 to 50,000 patients, unless there are exceptional reasons as to why that might not be the case. Broadly speaking, that is due to rurality, which, as we can see in central Uxbridge, is not necessarily the case. So we've all of our networks are between that 30,000, and as you'll see from one of the later slides, actually some of them are quite large. So we've got our 7 primary care networks. It's one of the sort of points in the guidance is that practices don't have to sign up to a primary care network, but what they do have to make sure is that their patients are able to access the services delivered by the primary care networks. So where practices choose not to be part of a network, what they do have to do is sign a sharing agreement with local networks, so that no one misses out in terms of some of those enhanced services, which I'll come on to in a second. Because I think increasingly the direction of travel for primary care will be that the commissioning of primary care will be at scale rather than at a practice level, and that is something that we're going to have to make sure doesn't create inequity for our patients within the borough. Each of our primary care networks has appointed a clinical director, and they are responsible for the development of the network and making sure that it works very closely with the services that serve the population. So what we have done in Hillingdon is all of our primary care network clinical directors have also agreed to be the clinical directors for the neighbourhoods. So in essence, their role and remit is beyond primary care. It also spans into those community health services and mental health services as well. So don't look too closely at the map, because it might make your eyes go a little bit funny, but those are our primary care networks in Hillingdon. That's probably a slightly easier way you'll see in front of you to kind of see what practices where. So hopefully from councillors' perspective, you'll be able to sort of map through where you think your local practices are sitting within those collaboratives. So the size, as I say, does range quite a bit. So the largest that we have is the Hayes and Harlington Collaborative. So that is upwards of 70,000 population. That's a very large network down in the south of the borough. And the others really sit between sort of generally 30 to 40,000. We also have the Long Lane Group and the First Care primary care network. So again, those were 2 neighbourhoods that you saw on the previous slide that joined together. So whereas we've got 9 neighbourhoods, we have 7 networks because 2 of those neighbourhoods joined together and work more closely due to scale and some of the efficiencies from that. So some of the services that are included at the moment as part of primary care networks, so clinical pharmacists, we're increasingly looking at how we can make better use, probably one of the really skilled workforces that we have in the NHS, which is the pharmacy workforce. We talked a little bit about the role in hospital, but actually they have a really key role in the community and can do a lot of the work that general practitioners might do historically, so making sure that people's medicines when they come in and out of hospital are being reconciled, also making sure that people are taking their medicines in the right way, which is often more complicated than it sounds, and making sure that there aren't any sort of contraindications between what people are taking. It's often quite confusing for people, particularly when they are transitioning in and out of different settings of care, to know whether they should stop taking some of the stuff they've still got at their home in favour of what they've brought out of hospital. So there is really a lot of work that clinical pharmacists can do. We've got 10 that are working with our primary care networks at the moment, so we were slightly ahead of the game with that as well, and they are having an impact on also releasing general practitioner time, as well as improving some of the patient experience around that. So accessing additional appointments, some of you might be aware that we have extended access available in the borough. At the moment that's sort of commissioned by the clinical commissioning group, so ourselves. Going forwards, that will be really commissioned and potentially delivered, but at scale by the primary care network, so they will take on the responsibility for that. And online access is something that we are looking at very closely in terms of making sure that we can pilot and get a model up and running in the borough that again releases capacity for general practitioners being able to spend more time probably with some of those complex patients who maybe need a little bit more than 10 minutes in an appointment, and how well we can use some of the online access is going to be really critical to that. The multidisciplinary team, I won't talk too much about that because that really does pick up on the work that Kim was talking about earlier with the neighbourhoods. The voluntary sector support, so this is something around social prescribing, and it's something that we picked up a lot in the oversight committee around GP pressures and how much can we probably leverage a little bit more value out of some of the really good partnerships we've got with the third sector in Hillingdon, and making sure that people are being signposted into some of those third sector care provisions that isn't necessarily about medical care, but is about people feeling sort of activated, able to take care of their own health and well-being, and accessing some of those sort of broader voluntary sector services, whether that's befriending, weight management. There's a whole variety of things out there which, again, I don't think we are necessarily linking into as effectively as we can do, and the social prescriber is a really important part of that. And also accessing some of the specialist skills that might not necessarily be viable at a practice level, but which you could provide across a population base of 30 to 50,000. So there's a lot of opportunities really around primary care networks and moving those forwards. Those are just a couple, I won't go into those, but what we've done with our primary care networks is ask them to come up with some projects themselves where they think they might have some innovative ideas that align with the objectives of the CCG in the system, and those are 2 of the examples there. So one's around sort of having a slightly more collaborative approach to telephone triage across the patch, and one is around the high intensity users of the emergency department. So I think having those projects is really a good galvanising influence for some of those practices to start working together and think about really how we start to identify innovation and transformation, and then scale up where we see something working well across their peers in the borough. That is a bit around the neighbourhood working, so in future I will speak to CNWL in advance to make sure that I don't just repeat a lot of what they've said, but that is helpful that we are saying the same things. So the next steps really is for the primary care networks to continue to identify some of the priorities and the topics that they want to work on, both internally in their practices but with local partners. I talked about the extended hours arrangements. That's something that will be coming on shortly. Clinical pharmacists and social prescribers, again building up the workforce around there. And then there are 5 service specifications that will start to come out nationally that primary care networks will need to be delivering. So one is the structured medicines review, which very much builds on a lot of the work that we're already doing around prescribing. The enhanced health in care homes, and again that really will potentially supersede, but I think probably just underpin the work that we're already doing around enhanced care in care homes, so that helps strengthen that. Anticipatory care, which is really around the care planning, personalised care and support with early cancer diagnosis, which is really critical for us because we do know one of the areas that we could do better on is diagnosing cancer at an earlier stage, so that will be a very critical one. Those are coming online over the next sort of 2 to 4 years, so they're not all coming out in April. There's a sort of pipeline of those. And the two service specifications for 21-22 are really around prevention and diagnosis of CVD and neighbourhood inequalities. And I think a lot of the work that we're doing in HHCP with Hillingdon Health and Care Partners, looking at the populations locally and making sure we know what the needs of those local populations are, and going back again earlier to Kim's point around making sure that the resources that we allocate to those neighbourhoods reflect the demographics is going to be really key with that. So, do you want me to go on to the operating model, or any questions on that one first? Shall I skip through?
Councillor.
I'm listening to all you're saying, and it's all very well and good, and I'm glad I'm not actually usually on this committee. What concerns me, and what concerns the residents of the ward I represent, is how you get an appointment to start with a doctor, and this 10-minute, well, you know, somebody might only want a minute repeat prescription, another one wants longer, can't get it. But the one thing that keeps coming up with every resident who ear bashes me is that when they finally get an appointment, and sometimes they're told, well, we haven't got anything today, ring tomorrow, and ring tomorrow. So, you know, this 3 days, seeing 3 days is a fairy story. But what they constantly keep saying to me is, they're told there's no appointments because everybody's going to the doctors, and yet you're going to the doctor's surgery and there is a sign saying we're taking on new patients, and they're saying if they can't cope with the patients they've got now, what the hell are they doing taking on more patients? So the patient who's been with them 10, 20 years can't get 10 minutes for a week or more. And yet here is a new patient, sign up, go in and see the doctor, and there's an inequality there, and that needs sorting. And I'm very concerned that you're never going to solve the problem until you actually start employing some more doctors.
So I think the workforce pressures are a real challenge for us, and we know that Hillingdon, as a borough in North West London and in London, is one of the more under-doctored areas for a variety of reasons. I suppose that there's a few things. So, I mean, the actual logistics of access, one thing I would say is that if people are struggling, there are people to contact. So I think it's obviously people are talking to you, but I think unless we know where people are struggling with particular practices, it's difficult for us to have a conversation about what those processes are. So I would really encourage people to have a look, go to the CCG website, look at who you can contact, and signpost people to contact us, because then we can figure out which of the practices might do things differently. Yeah. Yeah.
Unless you start promoting it out there and telling people, signposting them, and you're not going to get it in the doctors, because the doctor doesn't want.
No.
So you've got to get that information out there. It's very well me saying go to X, go to Y, but you've got to find an avenue where it can get out there.
Yeah. And
we've recently had a very lengthy review of primary care and GP services. Councillor Lamana and Councillor Prince were on the committee, and that report's going to Cabinet in January, and it makes suggestions and recommendations for a whole range of ways of dealing with exactly what you're saying. And one of the sessions that we had, and Caroline was there, I think, was we brought together the Chief Executive of the CBA and Citizen Advice Bureau, CBA is Criminal Bar Association, which I'm on as well, but of the CBA, CAB, and they have an extraordinary network of different offers for people. Because one of the things that we were recommending was trying to find ways of diverting people in the first instance, perhaps away from GPs, because a triage that needs to that should say to someone, well, you may not need to come and see a GP, but what you might need to do is to go and see these people or some other person, and to have that sort of flow. So to have that connection between citizen advice and the doctors. The doctors thought that was a really good idea, because a lot of their time is taken up with people who present as being unwell, but actually the root cause of that being unwell is something else.
Can I suggest you start using Hillingdon people for this exact thing? Because, you know, you open it. That was another. Flag waving, but not.
Yeah. That was another avenue of information, certainly. One was screens in GP practices that routed people to a problem. So you essentially said what your issues were, and that would then route you to an organisation that could help. Another one was for people with smartphones. They could have a similar thing, but could get immediate access to those things. And the citizens advice people were saying, look, you know, we have the most extraordinary range of opportunities and help people that can help with various things that coincide with certain types of illness, because one leads to another. The whole issue about information and getting information out to residents is something that we were very concerned about and dealt with in a fairly, well, about 3 or 4 meetings actually, where different people came along and made suggestions for us. So it's well underway. It's well underway. Anything else?
Sorry, Caroline. With the improvement that is happening with the network, have they looked at the target time for people to make appointments? Because that's a big issue. And if you have an emergency appointment, you've got a triage. If you don't have an emergency appointment, you're looking at 3 to 4 weeks before you can see your GP. Have they looked to see how they can reduce that time for residents?
Yes, so I mean they're in very, very early days at the moment, but exactly that telephone triage that's going in the north of the borough. I think one of the things that often gets reflected about general practice is that we have 45 practices in Hillingdon, and there is a variety within that as to how people run their access and how effectively that works from a patient perspective. And I think the opportunity around particularly things like the telephone triage, and I'll come on to online consultation in a second because I think there's a real opportunity there as well, is to standardise some of that. So much like, we talk about the hospital and standardising processes, the more we can be standard in the way that our residents are accessing primary care so that people know what to expect and know how to access, the better. And I think those expectations around if you are in need of an urgent appointment, how do you access it and how quickly will you be seen, and if it's a standard appointment, I think the primary care networks are a really key way of getting that, because we're starting to work with practices in groups of up to the Hayes and Harlington is 72,000 population, so it's big groups of people. And I think the communication out to patients about the expectations can be clearer as well then, because you're dealing with a much larger cohort of people to communicate. So yes, that is exactly, some of that access work is really important for us to pick up through primary care networks. Just on the online consultation, because I know people have very different views about the relevance of it and how likely it is to be effective. We do have in other parts of North West London areas where this is up and running very effectively. So in Brent there has been a pilot of the e-consultation running, and they're showing some really good impacts in terms of the capacity of some of their smaller general practices being released, because they're able to close down some of those consultations online. So people don't even need to come into the GP surgery. They're being triaged and managed outside of a face-to-face appointment. So that has been shown to have a good impact elsewhere in North West London, and that is something that we look at. It's not right for everyone, but I think for some people actually that access quickly to a GP opinion, like whether it is a prescription or something that actually they just need quickly, can be dealt with through an online process rather than necessarily someone having to ring up a surgery and then go in and see a GP. So.
All right, Councillor Allen.
When the residents in the south of the borough know that the number of doctors they got are far less than per capita than the north, can I ask why the pilot scheme is being done in the north first, when it's clearly the south of the borough that needs?
So that was down to the individual primary care networks deciding what they wanted to pilot. So that's not to say it won't happen down in the south, but it happened to be that network in the north of Hillingdon has looked to do the telephone triage first. So, but one of the things that, as I say, we really do need to get on top of is how we quickly scale things up over, because the last thing we want to do is put something in place that then drives more variation across the patch. But really the idea of getting those projects up and running was for those practices to start to work together on a project, and as and when it starts to be successful, then we can look at how we roll it out across the borough. So that's...
Well, in fact, one of the again big areas that we looked at in our GP services review was, and as Caroline said, we're under-doctored, as it were, in terms of numbers across the borough. And one of the things that we looked at was, and it's one of these knock-on effects. How do you relieve pressures at certain points in order to attract doctors to the whole borough, the south as well as the north? And it was very revealing. Various reasons as to why that there were fewer doctors coming in, but being able to deal with those issues will make it easier. And by the time we'd finished, the GPs were absolutely certain that more doctors would come once they had addressed the various pressures that they were concerned about.
Yeah. Over 5 years ago, we had the Woodland Centre at the top of Church Road, and all the residents were told there was going to be a new service there. They all applauded. 5 years on, the building is sitting there. We're told that the doctor's surgery is not coming, but flats are coming. Then we go down into the town, the HESA service. There used to be 2 teams used to work there, the Orchard and the HESA. Brilliant service. Residents were raving about it, were singing praises everywhere, and then all of a sudden told, no, it's not needed anymore. So clearly, somebody's got to get their hand on the tiller and start saying, look, this needs... The will is there, the money must be there, because we're told the money's there now, so let's get it done.
A very welcome refrain. Dr. Hadjoff.
Thank you, Chairman. I think there are a lot of issues and lots been touched on. I think Caroline's point about online consultations is important in that it can take away some of the strain, so allow those people who've got more complex problems more opportunity to get seen sooner, but they're not going to be for everyone. Telephone consultations certainly work, and we've known that for a long time. Those also can deal with the repeat prescription query or that sort of thing, and actually the repeat prescription query can be dealt with by even quicker means. So hopefully some of those things will take the load off. But I think that there's another piece that perhaps just to highlight. There are other areas where appointments are delivered, where primary care is delivered, which residents aren't necessarily aware of. And we need to, and where there is often capacity. So extended access hubs and things like that. And we need to make sure that people really are aware of them. Where I live, which is not in this borough, so I'm not criticising anyone locally, the GP surgeries don't actually have any, they can't refer you into the extended access arrangement, and they don't signpost you to the extended access arrangements. So it's only because I know about them that when I called up for an appointment 6 months ago and I was told it was going to be 3 weeks wait, I just knew to go to a particular website and find the phone number and phone the phone number and make an appointment and see someone that day. And it's only because I know about them that I could do that. Now, that was not in this borough, it was in another borough. I know that we're better here, but we could certainly do more around making sure that people are signposted, because very often when you can't get that appointment at your own surgery, actually you could get one somewhere else, and that's open. But you don't know that, and you don't know that you don't know it, if that makes sense. So I think that there really is a piece around making sure that that communication, and whether it goes on the answer phone of the practice or the or on the board outside or whatever it is. There's 100 different ideas. We need to find a way to be a bit smarter about those messages, because there is capacity in the system. It's just not always where you expect it to be. Thank you, Chairman.
All right, thank you. Councillor Andrew.
I have a question about Michael Sobel House. So there were some concerns over the use of equipment before it was closed. Are you happy that the newly opened unit is well equipped, and is there any issues?
So yes, thanks for asking about Michael Sobel House. I think the planned opening is now the 5th of January, I believe, for the inpatient unit. And we have done sort of extensive mobilisation checks around equipment and an estate there. So all of the feedback has been that it is as expected, and there is the kit is available as specified, and that it's ready to go in essence. So there's no outstanding concerns about kit not being where it was expected to be. So, yeah.
Just going back to Michael Sobel House, as it were, and it may have been you were going to come on to it anyway, I suspect you were. We're at a point now where there was a launch on Monday, or at least an event on Monday, and something similar at the weekend, I think. The governance now is split, I think, between Harlington Hospice and Michael Sobel House Charity, and then NHS in some form or another. So the former commissioners are out of the picture, which a lot of people will be very happy about. And things are on track for it to be reopened as it should have been previously. All right, that's great. Staffing and all that sort of thing, everyone's happy with that? Okay.
Regular mobilisation calls over the past couple of weeks between ourselves and the providers that are handing over, and the estates are in place, the staff are in place. So originally we were hoping it would be live from the 16th, but there's just been a few sort of snagging issues to work out, so we're going for the 5th of January instead.
And we'd always acknowledged pragmatically that this was, albeit a long term, but nevertheless a stopgap in terms of provision and siting. And it was suggested, I think, when Michael Breen was here previously from the charity, that almost a sort of old sort of platitude that once it's opened, they then need to look way ahead for a much more permanent site, which also feeds back into what we were saying previously about sites and the estate and so forth, because I know that one idea is that it would make sense for a similar sort of, for the unit to be on a hospital site, because it makes sense for it to be there. I mean, not all hospices are on hospital sites, but if they can be, it's obviously a lot better. So Karen, is that sort of work in being or in plan at least? I know it's very early days. In fact, it's before early days, but.
So I think, as you say, I think the thought and the intention is there from Michael's side. I suppose from our perspective, really, we've been focused on getting the current unit back up and running. But I think all of the conversations that we've had previously have been really around refreshing the end-of-life strategy, sort of in its broadest sense as well, and making sure that we get the right services in to support people to end their life in the place of their choosing. So what we were keen to do was really get to a point where, the hospice provision was back up there, and then open up a very comprehensive conversation and dialogue with residents around what the future looks like. Obviously, Michael Sobel House Charity have got a clear vision about sort of looking to the future and looking about what their strategic plans are, and we'd want to work really closely with them on that. So, I think once we've got the current sort of facility back up and running, we'll start to think about the next
I accept I may be jumping the gun somewhat. Right, going back to what you were saying about PCNs. So, and I'm very interested in the whole business about pharmacists, because we had a lot from them in relation to the GP pressures issues. Is the idea that particular pharmacies and particular pharmacists should be sort of more aligned with particular practices, so there's a much better dialogue and flow of service between the two?
I think there's two bits. So there's definitely the community pharmacy element that we would want to play into the primary care networks, so that those networks, generally there's usually pretty good relationships between practices and the community pharmacies they work with. The doctors and the pharmacists know each other, but obviously this is an opportunity to look at scale. This is more around the sort of the pharmacist workforce, and potentially those pharmacists working in the practice. So and there's nothing to say that there couldn't be some sort of opportunities around people who are, and we already see people who are currently working in community pharmacies rotating in and out of those positions. But the pharmacists here are pharmacists that would be employed by the primary care networks or by our GP confederation, who would have the sort of express purpose of clinically working with the patients. So I think there are opportunities around both of those, but it's the sort of pharmacist workforce that this is talking to, probably slightly more than the community pharmacy element.
All right, so I think the next little bit is about the North West London CCG operating model.
Yes, sorry, Nikki, I've talked too long. But I can make a start.
Yeah.
Okay. And I think anyway the councillors can see the
We've
papers.
got the paper, yeah.
And I'll try and remember what it was that I said. So stemming back from the long-term plan back at the start of 2019, there was an aspiration for CCGs to really move towards having a single CCG for each integrated care system. And in North West London, thank you. In North West London, that really sort of is at a North West London footprint. So moving forward, the integrated care system, as distinct from the integrated care sort of partnership or provider, the integrated care system is the North West London system. And nationally, CCGs are moving to align themselves at that scale. So for us, that's kind of 2.2 million people, and it's all of the 8 boroughs of North West London. There was a piece of work done earlier on in the year, which was an engagement exercise really with stakeholders, including local authorities and also sort of CCGs and local sort of patient and public involvement groups around really the implications of moving to a single CCG by April 2020. And there's quite a lot of very rich and useful feedback that came from that exercise, which meant that in September, the governing bodies in North West London agreed that they'd actually recommend to move towards a single CCG in April 2021, so have a transition year really between 2020 and 2021. But in the meantime, what they would do is commit to move towards a single operating model, so that we do try and streamline the way that the commissioning is working in North West London. And potentially streamline some of the governance around that, and really focus on delivering the financial recovery that we need to in the next sort of, well now, year and a bit to April 2021, so that by the time we get to that point, the system in North West London will be sort of closer to balance than it maybe is at the moment. And within that, I think what we have agreed is that there will be always a need for local teams and a local presence, as well as the sort of pan-North West London work, and those local teams really will form the start of a transition to local integrated care partnerships. So the functions that we are keeping locally, we would hope will move towards being a support function for whatever those sort of local providers come together and collaborate as part of an integrated care partnership. We already have the HHCP sort of alliance agreement, so again in Hillingdon we're maybe slightly further along than other parts of North West London are, so we're in a slightly different position from that perspective. And those local teams will really continue to have the responsibility for working with our GP memberships, our 45 practices, working with community-based services, developing all of the primary care networks work, all of the neighbourhoods work that we've just talked about, and really maintaining the relationships with our local authorities, both sort of from this type of perspective, but also with our local commissioning arrangements, and with Health Watch partners as well at a borough level. So sort of our next steps really are that our structures and the budgets for all of those different teams are currently under development, and we are proposing that they will probably be published for staff consultation towards the middle to end of January, with an implementation start date of a new management model, probably from April. Initially we said March. I think April is probably a safer bet. And the only thing that I suppose I haven't included on here at the moment, because it is still in discussion, is really around the configuration of some of those local teams. So at the moment we have 8, 1 per borough. The proposal is that going forwards there might be sort of some value to be gained from bringing some of those teams working more closely together, partly for efficiencies of scale and partly around relationships with providers. So some of those groupings that are currently being discussed at the moment are the Brent and Harrow CCGs might have local teams that work more closely together, that Ealing and Hounslow would potentially work more closely together, and that what's currently sort of known as the Tri-Borough, so that's Central London, which is Westminster, West London, which is Kensington and Chelsea, and Hammersmith and Fulham work closely together, and that Hillingdon remains as a sort of standalone local team. So that's currently what the conversations are revolving around at the moment. So happy to take any questions.
Thank you. That's I think that's very good news, isn't it? In one sense. Well, you know that what the council's view has been, and those aspects of the council that deal with health matters, and including this committee, our view on this new model, because we think, to put it bluntly, that we'll lose out because we are much further forward than lots of our neighbours and partners across London, and inevitably where things are not going so well, resources get put into that sort of area rather than maintaining somewhere that's doing well, and that's the sort of concern. But if there's going to be a recognition of the good working relationship and the good things that have happened between our CCG and us as a council and the health economy generally, then and that continues, then I think that's what I mean by cautiously saying it was a good thing. Is that right, or?
So I would echo what you said. I think one of the things that we do need to think about going forwards, though, is that across North West London, we are increasingly looking at what we talked earlier about where some of the growth is coming from in the patch, in terms of, you know, it's not necessarily purely Hillingdon Hospital isn't necessarily purely sort of dealing with Hillingdon patients, and I think as we go forward and think about the integrated care working, we are going to have to look sort of beyond necessarily the Hillingdon boroughs and make sure that we sort of are working very closely with our colleagues in some of the other boroughs. And so what we don't want to risk is becoming a kind of an isolated, you know, an island, glorious island on the edge of North West London, because there are interdependencies for the system with other boroughs, so we are going to have to work on that. But yeah, I think there are some opportunities as well in terms of how we can move things forward.
All right, so cautious optimism is good. All right, good, excellent. Okay, well, unless there's any other questions for Caroline, we'll move on. And Dan, anything that councillors want to pitch in on anything?
Just a couple updates, to be honest. We've had Turkai Mahmood has stepped down as interim CEO. He's rejoined the board as vice chair, and I've taken over as managing director now. I just want to touch on a couple points. We've recently published our sexual health services review by Young Health Watch. That's actually online as of about an hour ago on our website, so that can be accessed. It worked out very well. There was a few issues that were thrown up by it, mainly to do with confidentiality in some of the pharmacies and clinics, and some concerns around the online and telephone services as well, mainly some garbled pathways and things like that they were concerned about. Moving on from that, our Young Health Watch is carrying on with its good work, and Kim, who runs our Young Health Watch, has been rolling out her mental health and wellbeing program in the schools. We also had in September the Health Watch annual conference, where we were nominated for an award, which unfortunately we didn't win, but we were highly commended for it, and also our previous win for the discharge report was mentioned again quite heavily, so we were still rated up there quite highly. Beyond that, and it sort of links actually to what Caroline has been talking about with the PCNs. In November, we piloted a roadshow event at the Harefield Residents Association, where we were taking the concepts of the PCNs and neighbourhoods to members of the public just to explain what they are, because obviously it's very complicated structures and we know that there's not enough information out there for the public. So we've taken that, all the feedback that we received and also how it was received, the information, back to our board to discuss, and we're hopefully going to be coming out with a slightly more streamlined presentation, which we'll be taking around. At the moment, the minimum will be essentially one roadshow per neighbourhood, but obviously we plan to hit every single community group that we will be able to, because we want sort of key members of the community to get the information out there and spread it around. And we'll also, there's a few extra things which, whilst they're not directly linked to the PCNs, things like the extended access hubs, we know that because there isn't enough information out there, people won't know to use them, simply just going through 111. So trying to get that information out there, hopefully just to reduce some of the pressures as well, just so people know about it. So that'll be more or less carried out throughout 2020.
Any questions? Yes, Councillor Andrew.
What are the timescales for the roadshows?
We aren't committing to anything at the moment. Because ideally, from the feedback that we receive, we'd like to produce a report, sort of mainly aimed towards the CCG, just to explain people's concerns and things that they're happy about with the PCNs. So I personally would like to run it throughout 2021, and more or less, I think once we've hit every single neighbourhood, quite thoroughly, then I'd like to produce a report. But I think it's one of these things that needs to be an ongoing one, because certainly the one that we did visit more or less immediately said, oh yes, can you come back in a year and talk to us about how things have changed? Because it's a dynamic system that is changing and it's developing, they're going to want to know what's different a year later. So I think it might be one of those things that's going to be an ongoing project for us, but if it's a consistent bit of feedback that we can get from the public, then we're all for it, really.
All right, thank you. Thanks very much for that, Dan. That's great. All right, well, we'll move on to item 6, which is the children's dental care services. People don't have to stay if you don't want to, because we're going on to many different things, but if you want to, that's great. All right, so item 6 is the children's dental care services scoping report, which you'll have all read, and this is obviously the precursor to the select panel, and Liz, who will be, I think, our Democratic Services person again, has done an excellent job on this. It's obviously focused on what we dealt with last time in terms of children's services, but inevitably these panels tend to range all over different things, which is why we've got the personnel on it that we have. There's a lot to cover, as we discovered. Thanks very much. There's a lot to cover, as we discovered last time, and there's quite a lot in there. We've already had offers for help from dentists, from community dentists, from private practitioners and all sorts of people, because they've picked up that this is going to happen. So, and again, I think we'll, to an extent, we'll be led by what we're being told and where we need to go with this, because there is a lot to do, and also to hold quite a lot of different people to account in terms of service provision and so forth. So if everyone's happy with that, we can agree that, yes? Okay, and the first meeting that we've got is on the 12th of February, I think it is. Yeah. Oh yes, because you're on it, yes. Right, 12th of February. Okay, that's good. Everybody happy with that? Excellent, good, right. Work programme, item 7. Nikki.
Our next meeting on the 14th of January is to look at post offices. You'll be pleased to know that this time they are actually attending. So look forward to welcoming a gentleman called Owen to our meeting. I've already provided him with a range of questions, but obviously members are more than welcome to come up with their own on the night or beforehand. Insofar as our subsequent meeting in February, it's going to be looking at crime and disorder. So I need ideas from members as to what specifically, as well as the general update that we'll be receiving, is there a specific topic that you'd like to cover at this particular meeting, so that I can invite the appropriate agencies from, say, Hillingdon Partnership, rather than all of them?
Well, should we do that, as it were, rather than trying to think of things tonight? let you know by what date, do you think?
As soon as possible, really.
Last week.
Okay, if members could please let me know by the end of the first week of January, so that will be the 10th of January, so that I can get back to whichever agency it is. That would be great. 10th of January. One of the other items on the work programme is the Mount Vernon Cancer Centre review. I mentioned earlier that I have actually been in contact with NHS England about this, and they have actually been keeping me up to date. I have included a little bit of information at paragraph 6 within the work programme report about what's happening at the moment, and when it is that they're likely to come back to us. I've been advised it's going to either be the 11th of February or March, depending on how far they've gotten with the process, because obviously they need to be able to report something to us. And in the meantime, I've been liaising with, as I mentioned earlier, one of the Democratic Services officers, the manager at Hertfordshire County Council, who is arranging a site visit for her members to Mount Vernon, and wondered whether we'd like to be involved in that as well. I'll keep members updated on any information that I receive. And finally, as was mentioned earlier, and this has been on the work programme for a while, about having an additional meeting with Hillingdon Hospital. We were previously looking at before Christmas, but obviously things got quite busy, so it didn't happen before Christmas. So I will contact members outside of the meeting to identify a date that you are available, or the majority of you are available.
All right, thank you. I think that it will be very useful for us to do that. There's so much. I mean, when you think about the reaction, as we'll all remember, to the CQC report and how that was handled, I mean, we weren't very happy with that at all. So to give the new chief exec an opportunity to come along and tell us, I fear that we'll hear what we've heard before. But because in a sense, inevitably, that's what chief execs end up doing. They look at all the problems and see what they can fix. But I can't help but think that it's going to be not dissimilar. I'm sure that Sarah has a great plan in mind, but an awful lot of the response to the report was, yes, but it's the building or it's the estate. And I don't doubt it, because it affects almost everything that they do, let alone people having to work there. So let's see what they have to say, but it will give them the I'm sorry? Yeah, of course it is. Yeah, it is, yeah. Well, it's difficult, but it's been a very difficult issue for a very long time. All right, so we've got that all lined up for next year. Anything else from anybody else? No? Okay. Oh yes, well, I was going to say to wish all our viewers and listeners a very happy Christmas and a great new decade, and we'll see you all next year. Okay, thank you.